Well, good afternoon, everyone. Thank you for joining AgeWell's Navigating Eldercare webinar. We have two fantastic speakers today who will speak about age-related memory loss, dementia, and other cognitive changes, and of course, provide you with information and resources. We have Rochelle in the background running the show for us, and she will help us later in the presentation to answer some poll questions. So quickly, an overview of our presentation today. I will give you some background about AgeWell, Middle Tennessee. Dr. James Powers will provide information about how to recognize cognitive warning signs and when your loved one may need an evaluation. And Cheryl Blanchard will talk about the community resources and services that are available. I'll show you how to access AgeWell's Eldercare Coach program. And of course, we'll leave time for your questions. So please, throughout the presentation, if you have any questions, please put those in the chat box and we will get to those. So if you're not familiar with AgeWell Middle Tennessee, we are a nonprofit organization founded 36 years ago to be a trusted resource and champion for older adults and family caregivers and to be a catalyst for solutions to unmet needs. As a trusted regional nonprofit, AgeWell offers a variety of educational resources, such as our directory of services. This is the only comprehensive impartial resource guide throughout Middle Tennessee. We have a series of caregiving guidebooks. We have a helpline. And also on our website, you can find the rubric care navigation tool. And all of these materials are designed to help older adults and their family caregivers plan, find assistance, and navigate care options. Thanks to sponsors and grants, these trusted print and online resources are free to older adults and caregivers in Middle Tennessee. So we are extremely fortunate to have Dr. James Powers spending time with us today to discuss ways to recognize memory loss and other cognitive changes in our older loved ones. Dr. Powers, MD, is professor of medicine at Vanderbilt University, where he runs the geriatric fellowship. He's also the associate clinical director of the Tennessee Valley Geriatric Research, Education, and Clinical Center. Dr. Powers received a BA from Wesleyan University and MD with distinction in research from the University of Rochester, followed by residency in internal medicine at Cleveland Clinic and Case Western Reserve University hospitals. He served in the commissioned corps of the U.S. Public Health Service, following which he was recruited to Vanderbilt to develop a geriatric medicine teaching program, which developed into the geriatric division. The Vanderbilt Geriatric Program now supports numerous faculty colleagues, a geriatric medicine fellowship, the VA Tennessee Valley Geriatric Research, Education, and Clinical Center, the Middle Tennessee Geriatric Workforce Enhancement Program, and the Vanderbilt Center for Quality in Aging. As the author of over 100 books, papers, and book chapters, Dr. Powers is in great demand as a lecturer and has devoted his academic career to geriatric nutrition, education, and healthcare quality and safety. So Dr. Powers, thank you so much for being here, and we're so looking forward to all the great information you'll be providing today.
Well, Nola, thank you so much for the kind introduction. And it is indeed my pleasure to support AgeWell as we do this webinar on behalf of caregivers, particularly related to the upcoming holiday season. The holidays can be a very stressful time, what with meal preparation, guests, cleaning, faith-based activities. If that weren't enough, how about the thought of finding out that your older loved ones are having some decline in their health or their memory? Well, that can make the holiday time very, very stressful. I'm going to speak to you about cognitive warning signs, an overview of dementia in general, what's involved in evaluating an individual with dementia, And finally, some topics related to the management of dementia and the family. If I've learned one thing in taking care of many thousands of older Middle Tennesseans and their caregivers, is that caregiver is the hidden patient as well. They are every bit in need, as much as the individual affected by dementia, for support and information. And we hope to address these concerns for you today. First of all, what are cognitive warning signs? If I have occasional name finding or word finding difficulty, is that dementia? No, it is not. But there are some warning signs that you should be aware of. Let's say you're visiting your older parents, perhaps other relatives, loved ones, and you find that they are getting lost, that perhaps they are repeating themselves. Maybe you find that one of the spouses says that they've had to take over more and more supervision, kind of directing another individual, reminding them about different activities of daily living or their hygiene. Or perhaps you find that they've had to take over bill paying responsibilities because of mistakes. Those are cognitive warning signs. And it can be heartbreaking to realize that this is the first time that you've noticed this. In truth, it may take up to 2 years for other family members to be aware of these problems as they develop. Perhaps we'll just use parents as examples. They've not been wanting to talk to you about their health. They've been kind of embarrassed. There may be other things. Maybe your mother has lost a shocking amount of weight. Maybe they're falling. There can be other medical conditions as well. And we know that these can be heartbreaking things to find on what would otherwise be a happy time of year for a holiday visit. But then you put on the mantle of caregiver and you need some information. And that's what we want to help prepare you for. Dementia is an overarching theme. There are many different conditions that can cause dementia. In general, when we evaluate a person for dementia, we make sure it's not something else, such as depression, such as missing medication for other medical conditions. In fact, we hope we can find those sorts of things because we can fix those very readily. Dementia is a chronic condition, unfortunately. And if it is truly dementia, unfortunately, we don't have a cure for that. That would be a Nobel Prize. However, it's important for you to realize that there are different types of dementia. About 70% of all dementia is Alzheimer's type. About 20% is what we call vascular dementia, mini strokes, if you will. People that have had diabetes, high blood pressure, heart conditions may be more prone to the vascular type of dementia. But in truth, Alzheimer's and vascular dementia can coexist. In other words, there's a lot of overlap. I'll mention 2 other types of dementia because they're probably something that you've heard about, but they're not as common. One is called frontal temporal dementia. Maybe 2% of people have that. And the other is Lewy body dementia. Maybe 1% of individuals with dementia have that. Lewy body dementia presents with a lot of difficulty with movement, stiffness, shaking, kind of a Parkinson's-like symptoms. So, and the frontal temporal dementia often occurs in younger people, maybe their late 50s, early 60s, often associated with some depression, aggression, behavior issues. Again, about 2% of individuals. So most of the time when we're talking about dementia, it's the Alzheimer's and perhaps overlap with vascular dementia. Does it make a difference? Well, Possibly if things like blood pressure, heart disease need to be controlled, but in general, no, we treat them the same, and there's no particular one treatment for any of these types of dementia. It's mainly support, and we're going to go into that. So what happens if you are concerned about dementia in a loved one? Well, it may be a challenge to get them evaluated. They may say, no, I'm fine. I do just okay by myself, as long as I don't go out in public, as long as I don't have to drive. Well, okay, that's good that they are able to manage in their own environment. We appreciate that. But it may be that there are some things that can be done. The evaluation for dementia, when the individual is ready and willing to have that, really consists of a complete history and physical. One of the things that we want to be sure is that we aren't missing something that is easily treated, such as a thyroid disorder, a B12 deficiency, anemia, perhaps some kidney disease. These things are very effectively treated and can really improve a person's cognitive status. So can such issues as depression. It's very common. About 20% of us are depressed out there, and there's a lot of folks that haven't been identified. And there are wonderful treatments to help this, and that can improve cognition. We do know that good cardiovascular health and good medical condition, taking your medicines regularly, actually help you maximize your cognitive function to function at a higher level. Making sure that there are some medications that should not be taken, sleeping pills, sedatives, anti-anxiety medicines need to be very carefully evaluated. And we do that as part of the dementia evaluation. So what you get after you have a dementia evaluation, you've had history, a physical, some blood tests, possibly some x-rays may be indicated. But there's unfortunately no one test that says, aha, this is what you have. What we do is we rule out all the treatable things. And I know that can be very dissatisfying. You mean there's not a blood test to prove I have Alzheimer's? Actually, it's a combination of the clinical symptoms, the physical exam, laboratory tests, and really putting it together with a trained clinical individual. There's at this point not a specific one test that has to be done, like an MRI or a spinal fluid analysis. Those are done to rule out other conditions. Again, I realize this can be very dissatisfying, but we have to be honest about that. And as I evaluate patients and families and talk with them, this condition of dementia has to be thoroughly explained and what we can do for it. A clinician who evaluates a person for a dementia has to be very good at communicating. To just say, well, you don't have X, Y, Z, you have Alzheimer's, goodbye, is not the way we want to be treated. Nobody wants that sort of treatment. Many primary care providers can actually do a very good job in dementia evaluation, going through the procedures that I just mentioned. Some of them may request a referral for make sure that they're on the right track, or are there any recommendations for treatment? That's perfectly okay. But I will tell you that working through the primary care physician, particularly if they're an understanding individual, generally they have the patient's best interest at heart and can communicate in a patient-centered way. Taking care of the individual with dementia involves really looking at the whole community, resources, community in the community, support for the caregiver, different medications may be indicated, and all of those things really need to be evaluated and changed as time goes on. So really keeping the primary care physician in the loop, I would say trying to keep them in charge is really what most of us in the geriatrics field try to do. We don't like to take over the care of individuals that have dementia, rather work through the support systems that are present in their community, their ongoing relationships with trusted care providers really needs to be maximized, and we indeed do that. What do we do to manage the dementia now? The diagnosis is one thing. As I tell individuals whom we train in dealing with dementia, the dementia diagnosis is just the first part of the care of the individual and the family with dementia. The management is really where you do the work, and that's indeed very important. So explaining things to the individual, explaining things to the family, there indeed are some medications that can be tried to help slow down the progression of the dementia, but unfortunately, nothing's available to improve cognitive function other than avoiding some of the risk factors that we talked about earlier. Certain medications can interfere with cognition. Certain medical conditions may need to be treated. Actually, the best prevention for dementia is actually good cardiovascular health. So promoting that even through a diagnosis of dementia is just critically important. It turns out that approximately 14% of individuals over the age of 70 will have dementia, 20% over age 80, and about 35% or even more over the age of 90. So dementia is really goes hand in hand with aging. Indeed, there are some families that have an inherited tendency, but even that only accounts for about half of the tendency for dementia. Getting old is probably the greatest risk factor for dementia, and it increases as you get older. Many are concerned about mild cognitive impairment, so-called MCI. What is that? Well, it turns out it's about as prevalent as those other diagnoses of dementia that I mentioned, about 15% at age 70, 20% 80, and 35% over age 90. The thing about minimal cognitive impairment is that it's not as severe as the dementia. In other words, if we do a evaluation of memory, they may lose a few points, but they don't have all of those dementia warning signs. They're not getting lost driving. Yes, perhaps the spouse has to remind them a little bit more, but in general, they take care of themselves. That's mild cognitive impairment. What we know about mild cognitive impairment is that, yes, indeed, it does give you a greater risk of developing dementia as time goes on. We feel, as best we know, about half of people with MCI will develop dementia with time. Approximately 10 or 15% of people with MCI go on to develop dementia each year. But we also know that about half of those people with MCI stay at that stage. They don't develop full-blown dementia. And that's very reassuring. And we try to provide that information to families as we evaluate them. I wish we knew more about what causes MCI, about what causes the different types of dementia. But unfortunately, our knowledge to date is quite limited. When we talk about managing the dementia from a medical standpoint, I mentioned that there were a few medicines that are sometimes used to help reduce the progression of the dementia. I wish we could actually turn the dementia around. That just is not possible for us with current knowledge and current medications. The medication that we often use is used to help improve the nerve-to-nerve cell communication. The most commonly used one is called Aricept or donepezil. This is a very mild medication, some but few side effects, generally well tolerated, and is used to help improve the nerve-to-nerve cell transmission, hopefully to improve cognition. It comes in many forms related to, you can get it called another name in a a long-acting tablet. You can get it, a relative of it, very closely related, in a transdermal patch. Sometimes it can cause upset stomach, and that avoids that if you use it as a patch. But basically, it improves the nerve cell to nerve cell transmission. The other type of medication comes under the name of memantine or Namenda, works on an entirely different pathway. And once the patient is stable on a medicine like Aricept, we then add Namenda. The idea being that if we improve nerve transmission through two different pathways, we may help further slow the decline in cognition. And those are our mainstays of medication. And again, I mentioned that the medical treatment is only part of the picture. The wise physician, the wise practitioner realizes that there are many other sources of support for the family and the patient. I want to say something about prevention too before I move on. And how does cardiovascular health improve your risk as far of your risk of reducing the chance of dementia? The brain actually gets about 25% of the cardiac output. In other words, every beat of the heart, 25% of that goes right to the brain. The brain is very much dependent on blood flow and good cardiovascular health. What we like to tell people from a prevention standpoint is that if you take good care of your cardiovascular health, blood pressure under control, eating well, making sure the cholesterol is treated, and if you are diabetic, making sure that diabetes is well controlled, you have a greatly reduced risk of developing dementia. This is generally the vascular dementia, but we know that Alzheimer's is also part of that. So good cardiovascular health portends good mental and functioning, as well as cognitive health. And if you do have Alzheimer's disease, keeping those other conditions, those cardiovascular conditions, which we can well treat and identify, under control, keeps a person functioning much better in their home and environment for much longer. When we identify someone that has dementia, we try to also talk to them about advance directives. Advance directives are your decision about future care. And it's a very personal thing. Again, we want to be very person-centered in the care of the individual with dementia. And at as early as we can identify the issue, try to give them the opportunity to make their wishes known. This involves perhaps a living will, perhaps deciding on the appointment of a healthcare agent, or maybe even a portable medical order to document to all other providers and emergency personnel regarding wishes about resuscitation, a so-called POST document here in Tennessee. There is a lot of help. You're going to get some information at the end of this presentation on sources of documents in sites, but thinking about advance directives, about future care is so important. Not only is it for the individuals so that they can make their wishes known, but it makes the caregiver, the family, much more comfortable because they know that they'll be doing things the way the affected individual wanted them to. I've been asked to talk about, just name the medications perhaps. I mentioned two different types. One is the Namenda or memantine that works, it inhibits an inhibitory pathway, if you will. It's the NMDA pathway. The other is the Aricept I mentioned, also galantamine and rhizostigmine are relatives. So there are three in that category. They improve acetylcholine is the name of the chemical, the nerve cell transmitter. Recently, we are aware that a new medication that works on the immune system, aducanumab, I'm sorry for the name, is available. We don't know how to pay for it yet. It's many thousands of dollars a year to administer that. Medicare does not yet pay for it. and it also can cause some bleeding internally. So it comes with risks, and we just don't have any good information about how well it's going to work. In theory, it should help reduce the buildup of plaque in the brain, which is what we know happens in people with Alzheimer's disease. Amyloid protein deposits in the brain cause brain dysfunction. I'm going to kind of transition here to let my wonderful colleague Cheryl Blanchard talk with you about more about resources. We really can't emphasize enough the importance of involving the rest of the family and community resources, keeping the affected individual with dementia functioning in the home and keeping the family unit together is really critically important. The longer that we can support the caregiver, the more that we can support the family, the more the individual who's affected with the disease can stay functioning at home in the community and probably have the highest quality of life. And with that, I'll stop. We'll have questions later. And I'll let Nola introduce our colleague, Cheryl Blanchard.
Thank you, Dr. Powers. That was excellent information. And I think it's really good to know that your primary care physician is a good resource for dementia evaluation. I didn't know that, and I think that's really a really critical piece of information. We did have a request in the chat, and I know you addressed it in terms of the names of the medications. Would you be able to put those names in the chat so people can see how those are spelled?
I will do so. Thank you.
Great. Thank you so much. And remember, if you do have questions for Dr. Powers, you can go ahead and put those in the chat and we'll get to those. So as Dr. Powers mentioned, to provide information on caring for a loved one with a dementia diagnosis, the available resources, and really importantly, how to care for yourself while you're caring for a loved one, I'm happy to introduce Cheryl Blanchard. Cheryl is a licensed social worker, certified dementia care specialist, and a certified case manager. She has worked with seniors throughout Tennessee for several years in a variety of roles and has focused most of her training on caring for those with Alzheimer's disease and their families. Cheryl has been speaking about Alzheimer's disease for over 10 years, and she recently joined Alzheimer's Tennessee as the regional director for the Middle Tennessee area. So Cheryl, I will turn it over to you. Thank you.
Awesome. Thank you so much, Nola. And thank you, Dr. Powers, for that great overview. I'm thrilled that you had to pronounce those medications and I did not. So thank you so much. I am going to pull up and share some slides with you just as we're talking today, just so you can have some visuals. So Dr. Powers did a great job explaining some of the things to look for and how you go about getting a diagnosis for your loved one. And I'm going to pick up for there. So you've got a diagnosis. What are your next steps? You know, that can be a really overwhelming thing to hear. And I've come up with kind of an acronym for you today, and I'm going to encourage you to be an ACE, to be an Alzheimer's ACE. So let's talk through what those letters stand for. So the first A in the acronym ACE would be for acceptance. You know, it's so easy as a family member of a loved one who's having these memory issues to say, you know, Dad's fine. He's just getting older. You know, he just forgot where he put the keys. It's really no big deal. But the problem with that is as long as we continue to deny that something's going on, we won't seek a diagnosis and we won't seek help. And you know, Dr. Powers may have mentioned that the earlier you get a diagnosis and the earlier treatment can begin, the better it's going to be for the person with dementia. So acceptance is the very first step to ensure that you can get the very best possible care as soon as possible. So as you're paying attention to the things Dr. Powers talked about, be sure that you're looking at your loved one with an open mind, and that you're really looking to see, okay, is this just a little forgetfulness, or is there something else really going on here? And if you're concerned that something else really is going on, be sure that you take the steps that he mentioned to go ahead and get a thorough evaluation. The C in the ACE is for cooperation. And it's really important for you to recognize that as your loved one gets a diagnosis and as symptoms progress, you may be functioning in two different realities. There's your reality And then there's the Alzheimer's reality. One of the hallmarks of Alzheimer's disease is short-term memory loss. So what happens is you share an experience, you have full recollection of the experience, but due to that short-term memory loss, your loved one with Alzheimer's disease may not remember it at all. Since they don't remember it, it really didn't happen in their world. So let's take the example of this couple sitting down to eat lunch. And this is a very common thing that happens. Maybe an hour and a half or 2 hours later, he may ask his wife, when are we going to eat lunch? And in her reality, they had lunch. She made it. She cleaned up after it. She knows for a fact they had lunch. So she might be tempted to try to pull him back into her reality. Well, honey, we already had lunch. Remember, we had turkey sandwiches. We sat at the table. It was just an hour ago. What are you talking about? Or maybe even, don't you remember? We had lunch. Well, the point is he doesn't remember. Therefore, in his reality, it never happened. He may be a little hungry. He may just be asking the question. So in a spirit of cooperation and doing something that'll make things so much easier for your loved one and for you, you want to step into their reality and just respond to that. He has no memory of having lunch. So you might say, oh, are you hungry? You know, I'm kind of hungry too. Let's go grab a snack. Or, oh, well, you're a little hungry. You know, dinner will be soon, so I don't want to eat a whole lot, but let's just go grab a little something to hold us over until dinner. Stepping into their reality instead of trying to convince, persuade, give evidence of drawing them back into your reality is one of the greatest things you can do to relieve the frustration and the stress created when you're trying to convince them that your reality is the real thing. Remember, if they don't remember it in their world, it did not happen. So operate within their reality in that spirit of cooperation. The E for being an ACE caregiver is for empowerment. And when we talk about empowerment, we think about both education and support. So being here today is a great step. You're getting a lot of good education here today. You can always reach back out to AgeWell for additional information. Their directory of services, that resource guide, is an outstanding book to have on hand. I refer to it on a regular basis. They've done a great job of gathering information about the community resources that are available here in Middle Tennessee. So if you don't have one of those, be sure to pick one up, or I think there may be Nola, you can confirm later, there's an online version of that, but you definitely want to have one of those as you're getting to know what resources are available in your community. And then of course the Elder Care Coach program, of course that exists to help you to make decisions, to learn what's available, and to get pointed in the right direction to the community resources. Also, if you have a loved one diagnosed with Alzheimer's or related dementia, I encourage you to reach out to us at Alzheimer's Tennessee. The website is listed for you there. We do have a number of online options available to you that I'll go over on that website. But one of the things that we really like doing is doing an individual caregiver consultation. So if you've got a diagnosis and you really aren't sure what the next steps are or what you need to do, please give us a call. When you call, we have 6 regional offices. You will speak to someone in your area. So I'm here in Middle Tennessee. I'm familiar with the resources here. I know what's out in the community. So please do reach out. We're happy to kind of guide you through accepting that diagnosis and then starting to look at some of the decisions you might need to make down the road. Online, we have our Caregiver Academy and our Live Well Academy. The Caregiver Academy provides short 3 to 5 minute videos for caregivers. If you just need a little bit of information, maybe don't have an hour like you're spending with us today, but just some quick education, you can go onto that Caregiver Academy on our website and pick up 3 to 5 minute videos on various topics related to dementia. The Live Well Academy is also on there for people who actually have the diagnosis. So a lot of great information for them as well. In the age of COVID, we've taken a lot of our live training and put it into online webinars. A lot of those are housed on our website, so please do take a look at those as well. In addition, we've got a lot of printed material we can send out to you, brochures, fact sheets, and anytime you call in and talk with one of us, we're happy to send that information out as well. We also have a 24/7 helpline. So if you're dealing with something and it's 2 o'clock in the morning, please call that helpline. There are trained folks there that are going to talk to you. And then by 8 o'clock the next morning, your local Alzheimer's Tennessee office is going to have an email about that call, and we're going to reach back out to you to help get you connected with the services you need and just kind of help you navigate everything that's going on. As I said, we have regional offices throughout the state. So this is a map of our regional offices. If you're not in the Middle Tennessee office, you can call that 1-800 number. They'll get you connected to the right office. Or if you call me, I'll be happy to get you connected to the office in your area. There are other sources of information in addition to AgeWell and Alzheimer's Tennessee. No matter what community you're in, typically you have something called an area agency on aging and disability. Many of us refer to that as a triple AD. So if you hear somebody saying the acronym triple AD, that's what they're talking about. Dr. Powers mentioned the importance of having an advance directive or a living will. So we have a great organization here in Tennessee called Honoring Choices. If you reach out to Honoring Choices, they've got all that documentation available. They can send it to you, and they can also explain to you how to fill those documents out so that your wishes are in fact honored. So do reach out to Honoring Choices if you'd like more information about that. If your loved one is in the hospital or a rehab facility, typically you're going to have social workers and discharge planners, and they have a lot of information about services that are available in your community. Many areas have 211, which is an information hotline. And then the human resource agencies are all over the state, and that's not employment agencies. The HRAs, as they're called, are agencies that provide a wealth of services to folks in the community. You may see the vans running around that maybe say ETHRA, ETHRA, or UCHRA. Those are all those HRA, human resource agencies that provide a tremendous amount of services in communities, transportation being one of the biggest things that they provide to residents. So make sure you find out what's available in your area. And I'm going to encourage you to do that before you need it. When you're in a crisis mode, when all of a sudden mom or dad doesn't have a way to the doctor and you don't know what you're going to do or how you're going to get them there, it's kind of hard to be in a fact-finding mode at that point. You're overwhelmed and you're stressed. So I really encourage you to do your research, find out what these resources are, what's available in the community where your loved one lives ahead of time. Go ahead and get that information together. So what kinds of care options might you need to think about? Well, there's a kind of two sides of that you want to consider. One is the home and community-based care. So that's if you want to keep your loved one in home. You know, most of us want to age in place and we want to stay in our home. So there are a lot of services available to help you do that. Things like non-medical personal support services. These are the folks that come in the house and help take care of your loved one while you're working and you can't be there. Respite care, that's provided by agencies like the Tennessee Respite Coalition. There are actually grants that you can get that can help you pay for some in-home care. And even some assisted living facilities have a respite program where your loved one can go and stay there. Let's say you had to go out of town for a weekend, or even if you had to be in the hospital yourself, you might want to take a look at some of those facilities and know in advance, what would my emergency plan be if I needed this respite care? Geriatric care managers are available to help you navigate caring for a loved one, and they're invaluable if you live in a different location than the loved one you're caring for. So if you live out of state, finding a geriatric care manager there in your program is a great person to have on your team. Find out about the adult day programs. Is there somewhere your loved one can go and spend the day to be engaged in activities and be around other people? Many areas have those adult day programs. And then transportation. If you're not there to take your loved one to all of their appointments, knowing what those transportation resources are in advance is very important. Most transportation companies require a 3-day notice of a pickup and a transport to a doctor or a hospital. So having that set up in advance is a really important thing. And then are we going to need to know about care options for outside the home? There are senior living advisors that can help you figure out what a good placement would be in assisted living or memory care. You know, what are the requirements for assisted living or memory care? Would my loved one even qualify for that level of care? So learning all of that in advance. I often hear people say, well, you know, we're going to take care of dad at home as long as we can, but when we can't anymore, we're just going to put him in assisted living, or we're just going to put him in a nursing home. It's not quite that simple, especially when we talk about a skilled nursing facility. They have to be medically appropriate for a skilled nursing facility. It's not like the old days where you just would place your loved one in well, we used to call them Dr. Powers old folks home or the retirement home. It's not like that anymore. It's very different. The biggest question I want you to be able to answer, though, is who pays for these services. Sadly, many families don't think about these plans in advance, and they get to the point where they need these services and they think that their insurance or their Medicare is going to pay for them. And I want you to understand it does not. Insurance and Medicare only pay for medical services. And you'll notice that first one up there, that non-medical personal support, that is not a medical service. Medicare is not going to pay for that. Geriatric care managers, adult day programs, your Medicare is not going to pay for that. Even assisted living and memory care doesn't pay for that. And for skilled nursing, it'll pay for a short rehab stay. But if you're talking about your loved one needing to stay there long term, Medicare is not going to pay for that. So I hate to be the bearer of bad news, but I want you to be prepared, and I want you to know in advance so that you don't get to the point where it's time maybe for a mom or dad to go to an assisted living, and that is when you find out there's no way to pay for that. How are we going to pay for that? So learn about these options now, kind of come up with your plan, find out what resources are available to assist you with those things. And again, making those plans in advance. In addition to knowing about those resources, think about who the folks are that are on your team. Again, when you're in a crisis, it's very hard to think about, oh, I know Nola's always said, she'll be there for me if I need her. She'll drive me to this doctor's appointment. I may not be able to think about Nola's name if I'm really in a crisis. But if I make that list in advance and I have that handy either on my phone or on the refrigerator, then I'll know who are the people that have always told me they'll be here for me if I need a ride. Oh, that's right, Nola. Let me call Nola and see if she can take me. Or who are the people that are always offering to run to the store or run errands for me? Oh, that's right. Dr. Powers is always telling me, Cheryl, if you need anything, let me know. So I want to write those people's names and phone numbers down where they are very available and very present. And when I have a need, I don't even have to think about who to call. Even before I do that, though, I've got to be willing to ask for and accept help. One of the biggest things I see in my work with caregivers is this stance of I can do it all, I can handle it, I can take care of my husband, I don't need any help, I don't want to burden anybody, I don't want to bother anybody. We're really proud and we want to be able to do it all. But it's okay to admit that you can't. And when you're a caregiver for a loved one with Alzheimer's, there's going to come a time where you just aren't going to be able to meet all of their needs without some help. So be willing to ask for and accept help. And all of those people who have made all those offers before, start taking them up on it. Another thing you can do in advance is make what I call a yes, please list. And that yes, please list is when that nice friend like Nola calls me up and says, hey, Cheryl, is there anything I can do for you today? I'm going to nod my head up and down, and I'm going to say, yes, please. And I'm going to go to this list of all the things that I have not been able to get done. Maybe it's going to my own doctor appointments. Maybe I haven't had a haircut in 3 months, or I haven't just had a break just to do something to take care of myself. So that's a hard thing for all of us to do. So I seriously want you to practice standing in a mirror when we're done today, nodding your head up and down and saying, yes, please. And when those people call you and ask, can they do something for you? Yes, please. It would really be great if you could. And then pull something off of that list that you need help with. And the last thing I would encourage you to do is get support from others who understand. Nobody gives advice like people who are not in your situation and don't have a clue what you're going through or what it's like. They always love to tell you what they would do if they were in your shoes. But really finding those folks who are in your shoes can be one of the most beneficial things you can do to care for yourself. So I encourage you to find a support group of other caregivers. They are walking the same path as you. Maybe they've already dealt with a situation you're dealing with, and they have a great tip that really worked for them, or a resource that we may not even know about. So maybe it's something that they found that I'm not even aware of. So we got a wonderful grant, and we're able to provide 3 online support groups for caregivers of folks with Alzheimer's or dementia. And if you have time to pick the one that works for you, that's fine. If not, please just reach out to us at Alzheimer's Tennessee, and we'll be glad to get you connected. In addition to these for Alzheimer's disease, we actually also have groups for caregivers for loved ones who have FTD. As Dr. Powers mentioned, there are many other things that cause dementia. We have an FTD specific care group. And then we also have support groups for folks who have an early diagnosis. So please do reach out to us. We'd be glad to get you connected to one of these groups. The most important takeaway for you all today is just to remember that you are not alone. There are a lot of great resources and agencies out here. We're here to support you and help you in caring for your loved ones. So please do take that first step, ask for and accept help, practice saying yes, please, and reach out to us and let us know how we can support you. Thanks, Nola.
Thank you so much. That was great, Cheryl. Quick question. If your loved one, maybe you don't have a diagnosis of Alzheimer's, but maybe it's a different dementia, can you still reach out to Alzheimer's Tennessee, or would that be a different organization? Can
No,
Alzheimer's
absolutely.
Tennessee help with other dementias?
Yeah, we serve folks with Alzheimer's disease and related dementias. And if there is an FTD specific, like I said, we do have the FTD support group, and we're happy to connect them with folks who offer the additional services like the Frontal Temporal Dementia Association and other groups like that. But yeah, absolutely, we serve folks with all of the dementias.
Oh, that's great to know. Thank you so much. And again, remember, if you have any questions, to just go ahead and put those in the chat. We should have a few minutes left here. But I did want to show you, as Cheryl mentioned, empowerment comes from education and support. So I wanted to share with you how you can access the resources that AgeWell has available through the Eldercare Coach program. So you would start by going to our website, which is eldercarecoach.org. You can peruse a variety of online resources. You can schedule a phone consultation, and we'll detail that on the next slide. And you can watch our new Eldercare Coach video series, which consists of approximately 15-minute videos that address topics important to caregivers. So the phone consultation is an excellent resource that's available right now. It is a complimentary 30-minute phone consultation. It is with a geriatric care professional. Again, visit Eldercare Coach. You can follow the instructions that you see here to sign up. And then you complete an intake form, which helps the geriatric care professional or the care coach prepare for your 30-minute call. So it is a scheduled call, and we can do same day if it's early enough in the day. But that gives the care coach time to research and provide the resources that you will need specific to your situation, and provide you guidance that can help you on this journey. So it's really designed to help save you the frustration and the time of trying to do your own research online. So again, it's an excellent resource, and I really encourage you to take advantage of that. All right, we would like your input now on a few poll questions. This might take a few minutes, but they should be pretty easy for you to respond to. So we want to know if this webinar has increased your knowledge of normal memory loss and dementia screening. We'd like to know if you have a greater awareness of information and community resources that are available to you as a caregiver. We would also like to hear if you learned how to access the community resources for Alzheimer's and dementia care. And then we'd like to know if you plan to utilize any of these resources. And of course, if you do have comments or suggestions, you can put those in the chat box. So go ahead and take a few minutes to respond to that poll. We'd love to hear your feedback. And again, don't hesitate if you have some questions to put those in the chat. And we will rely on Rochelle to let us know how we're doing on our chat questions. We really appreciate any feedback that you are willing to give us. We did have a comment that was very informative, and participant took lots of notes. Thank you for that feedback. We do have we have time for a few questions, so please don't hesitate. We'd like to this is a great opportunity to ask Dr. Powers any questions that you have. He's obviously a wealth of knowledge and information, so we're lucky to have him as a resource today. And the same with Cheryl, so don't hesitate. Have any questions? The question was asked, will this presentation be available to access later? Absolutely. We are recording the webinar and it will be posted on our website. This is Friday, so probably next week, but excellent question. Yes, it will be available for you to view later on. And again, we invite you to share the link to the webinar with friends and family that you think would benefit. All right. We do have another question. How do you know if a person has progressed? Oops, I lost my question. From mild, oh, that's a great question. How do you know if a person has progressed from mild cognitive impairment to dementia? So Dr. Powers, that sounds like.
Sure, I'll take that question. That is a very real concern that families express. There are memory tests that are used to screen. There are several of them, so that if we use a different one, when a person comes in, they don't remember what they can't learn from having done it before. Generally, this sort of a screen can be done each year to assess how things are going. We also pay very much attention to what family is telling us. If the caregivers really feeling more burden, that's a concern. If there are some of the cognitive warning signs that I mentioned earlier in the talk, that's of concern. So we have a number of ways to assess for that. It comes down really as a clinical opinion. There's no one thing we hang our hat on, but that is how it is done. And a question about the memantine, or actually any of the medicines, if the person reaches later stages of the disease, what I generally tell families is that if we're really advanced and the person cannot recognize family members, that's a very advanced stage. Often they're not moving very much. They might be just from bed to chair function. It is okay to stop the medications with no harm done. Occasionally it becomes a financial question. Sometimes insurance doesn't cover some of the medications, and so they wonder, can we stop them if they're ineffective? And that should be done on a case-by-case basis after consulting with the individual physician. As far as referrals, there aren't enough geriatricians to do all of the evaluations for all the people out there with concerns about dementia. So my recommendation is that you first go through the primary care physician, and they will also be able to refer. If it's a behavior concern that's associated with the dementia, often a mental health specialist will be very helpful. If it's a problem with falls and movement problems, perhaps a question of a neurology evaluation. And there are a few geriatricians out there. Some of us who work at teaching centers are doing our best to train new geriatricians, but we also realize that training the family doctor, the family nurse practitioner, the provider, to take care of older folks, particularly with dementia concerns, is very important. So we train them to be good geriatricians for their own patients. There can be a long wait sometimes to come to a medical center to a certified geriatrician. There, unfortunately, we could use 7 times as many as we have right now. So it's a national, worldwide shortage. Can exercises like walking help? Yes, exercise is very important. And it helps maintain a person at their best. And walking is very good. Doesn't have to be jogging or swimming, although those are certainly possible as well. Exercise is good for cardiovascular fitness, and good cardiovascular fitness is good for mind health as well. And as far as the PCPs being able to differentiate between MCI and dementia, Many of the younger ones who have had geriatrics rotations understand these things. And increasingly, yes, we're finding very good evaluations out in the community. I can tell you the referrals I get are much more targeted to specific questions. The primary care provider generally is right on top of things and just wants to help with management. And we do a lot of that. Again, we like to work through the primary care provider, realizing that you have a relationship there with the patient, with the family, and they're in a very good position to provide person-centered care, perhaps with some advice from folks like myself and my colleagues.
Dr. Powers, if there's a family history of Alzheimer's, is it inevitable that I would get it?
We do get this question a lot. Again, the greatest risk factor for dementia is related to getting older. If you are fortunate enough to make it to age 90, you have a 35–50% chance of having Alzheimer's disease, whether or not you have a family history of it. Yes, you are more likely to have dementia if you have a family history. At best, we believe it's between a 25% or 50% explanation for the dementia. In other words, it's not the whole answer. And I wish we knew more about it. But yes, indeed, if there's a family history of Alzheimer's disease, there's an increased risk, but no more than 25 to 50% risk versus just getting older.
Okay, well, thank you. Well, that looks like all of the questions. So that
No, I
will-
think, sorry,
Oh,
I
go
think
ahead.
there was one above about continuing medication. I think it got hidden when some of the others popped up. Is it effective or recommended to continue to dose Memantine once the patient has reached the late stages of the disease?
Yeah, I did touch on that briefly.
Did you? Okay.
But, it's an individual decision. I think most providers recommend stopping the medication in the very late stages of the illness. But earlier on, there may be other reasons, side effects, for instance, or cost. Memantine can be costly. We are aware of that. And that should be something that you discuss with the provider. I will say that regarding the stages of dementia, we could do more seminars on individual topics within dementia, but one of the best ways, I think, I'll just advertise here, a book for caregivers. It's called The 36-Hour Day. This is written by Dr. Peter Rabins. He's my counterpart at Johns Hopkins, a wonderful fellow. He and the social worker in his office wrote this book. It's available anywhere, Amazon as well. You can get that, and it's a wonderful source of information about the different stages of the illness, as well as how you can help yourself, your own self-help, support yourself, caregiver care, sharing the load, channeling your compassion. All of those things are very well discussed in that book, and I recommend it highly.
Great. Well, thank you so much. I appreciate everyone that joined us today. And I especially want to thank Dr. Powers and Cheryl for all this just critical information. Again, the webinar is being recorded and we will post it on our AgeWell website next week. So please feel free to share that link with your friends or family or coworkers, anybody that you think would benefit from this information. And please don't hesitate to reach out to AgeWell if you have questions or need any additional information. If you think of something after the webinar, reach out. If it's a question, we'll get an answer for you to the best of our ability. So thank you again. Thank you everyone for joining and for Dr. Powers and Cheryl for presenting to us, and enjoy the rest of your day.
Thank you.
Thank you.